Okay, well, I guess we'll get started. Welcome everybody to Exploring Care Options and Trial Opportunities for Minimal Change Disease and FSGS Patient Session. Once we get started, feel free to ask any questions that you might have for Dr. Udani during the session. We will at the end have a Q&A, but if you have any questions, please feel free to put them in the chat. Well, it is my pleasure to introduce Dr. Suneel Udani, an adult nephrologist and physician research director at Nephrology Associates of Northern Illinois and Indiana. Dr. Udani is a native of Chicago's western suburbs. He completed his undergraduate master's in public health and medical school degrees at Northwestern University and University of Pittsburgh. He served as a chief medical resident at Cook County Hospital prior to returning to the University of Chicago for his fellowship in nephrology. Dr. Udani is the author of multiple peer-reviewed journal articles and has presented his research at national conferences and is the author of multiple textbook chapters on diagnosis and management of kidney disease. His focus is on glomerular disease and heart-kidney interactions. He is also a clinical investigator for the community-based renal research program and is a dedicated educator and advocate for patients with kidney disease. Dr. Udani, welcome, and it's a pleasure.
Thank you. Thank you for the kind introduction, as well as the invitation to be here today. I know this is a different environment than we're used to and a difficult time for all of us, but I'm hoping that people are safe and that they find this, the day as well as this session to be helpful. So along those lines, as you've already outlined, I really encourage people to ask questions. I have sort of a talk that I've developed, but really this is meant to be tailored toward you. And so if there are things that I'm saying that are not clear or things that you'd like me to elaborate on or things we haven't connected on or discussed, then that's what we really like to make sure we have time for. So I'll start out with some overviews and talk a little bit about therapeutics, and then we'll, as I said, move on to what questions people have. So these are my disclosures. So I think there's probably a fairly wide degree of experience with these diseases in the audience in terms of how long people have had them or what they've experienced with it. So I'd like to kind of walk through things from the basics in terms of defining the disease, and I'll give you some perspective from a nephrologist. So the first thing, these diseases in particular, minimal change disease and FSGS, is sort of odd names you'd think, and the nomenclature has been part of the reason I think we haven't made as much progress, or at least the classification system. It also is something that is very difficult for trainees to understand. I'll say even until I was a nephrology fellow focusing on glomerular disease, it was hard to understand where these names came from and what their implications were. So the two diseases we're talking about are, we refer to as minimal change disease and focal and segmental glomerulosclerosis. And what you have here in terms of the images, the top slide is a biopsy specimen of a patient with a minimal change disease, and the bottom of a patient with focal segmental sclerosis. And it's important to really pick apart the name to understand what we are referring to. So minimal change disease is really referred to minimal change because on light microscopy, which means after the kidney biopsy is taken and the sample is looked at under a regular microscope, the kidney looks pretty normal. It's minimally changed from a normal kidney. You really cannot necessarily identify that there is a disease state. It's only when you get to the very high magnification level, what we call electron microscopy, that you can see changes in the kidney, in the glomerulus, at the level of the cell called the podocyte, which is really the anchor of the kidney filter and how protein loss is prevented. But the concept of minimal change is just that on light microscopy, there's minimal change from normal. Focal segmental glomerulosclerosis, again, is really descriptive. What it's saying is that a foci, meaning a third or less of the glomeruli, the kidney filters seen on a biopsy specimen, have a segmental, an area of scar. And if you have, that is compared to if you have diffuse or global glomerulosclerosis, which means that more of the glomeruli have all scar. So this sort of classification system, as you can sort of appreciate, it doesn't really say anything about how that got there, why the disease originated, what was the cause of it. It really doesn't appreciate the large heterogeneity, large variation in these diseases, meaning that people with FSGS, where they have full-on nephrotic syndrome with heavy protein loss, low protein in the blood, fluid retention, versus people who just have protein loss, are they really different? Which they certainly are. How things develop, was this something that oftentimes we'll see really in a 2-week period, people develop 40 pounds of fluid retention, or was it something that was more indolent and developed over perhaps months, years, or longer? What about the associated kidney function and how those changes, again, speak to differences in the underlying condition? And what this has done is clustered conditions that are probably really distinct. Even within minimal change, there's probably multiple variations of that. Within FSGS, there is a multitude of variations that get clustered as FSGS. And so we have clustered things that really shouldn't be clustered, and sometimes separated things that shouldn't be separated. Minimal change in FSGS, to some degree, can be looked at as the same underlying biology. So, there are real implications for this. One is that it's difficult for people to understand what their condition really is and what the cause is, but also has strong implications in terms of how much progress we've made. In 2021, if you can believe this, even though we've known about these conditions, as Dr. Rose said earlier, for 50 years, we have 0 FDA-approved therapies, which is, as maddening as a clinician, I'm sure as a patient or a patient family member, even more maddening. And unfortunately, to date, it's not as if people haven't tried, but our literature has been, time after time of we call a negative trial, meaning that the intervention did not show that it was better than standard of care. And a big part of that was that, again, you cluster certain conditions together. And if you try to treat 18 different things with the same therapeutic intervention, and you don't see that it helps all 18 different things, of course not. And other specialties have gotten much better at this. Oncology is the one that we really look to say, okay, they have been much better at defining not all lung cancer is the same, not all breast cancer is the same, not all leukemia is the same. And so they have honed in on very specific aspects of each individual, and then have developed therapies to do that. Now we're getting closer to that, and I think that as Josh Tarnoff mentioned in the beginning, that we may have the first ever FDA-approved therapy for FSGS, and that's been a long time coming. A lot of effort from scientists much smarter than me, investigators like myself and Dr. Rowan, Dr. Cobb, who've tried to execute these trials, tried to pick the right patients for these trials. But I think that it's really our failures, in my mind, sort of start at the way we've defined these. And again, hopefully that will change, but have not yet. So if that being said, so what's actually happening? And I like to go through this with patients I see, and I know that some of this is going to be more information than you're familiar with or necessarily you may want to know, but I think it's important for people to understand kind of how we think about things. So ultimately, what we're referring to, what we're focusing on, is what's happening at the level of the kidney filter. So if you have, most people have 2 kidneys, and within each kidney there are the glomeruli, which is the filtering structure. And we are all born with about 1 million glomeruli, somewhere between 500,000 and 1 million in each kidney. And the kidney filter, the glomerulus, really allows for the blood filtration process to begin. And like any filtration process, there's some things should get filtered through and some things shouldn't get filtered through. And small things like salt and water and other waste should easily get filtered. But the makeup of the filter is in such a way that it should not let larger things through. Things like blood, protein should not go through. And so we know when that we see those things that there is a issue at the level of this kidney filter. So what is that structure that prevents that? And that's where we look at this, what's referred to as the podocyte, and you'll see these little blue ones on these images. And the way I look at the podocyte again is sort of the anchor or the foundation for this filter. And the metaphor that I've used for people, and I hope this helps, is see you have an open circle, an open drain, and you on each end of that drain start to interconnect thousands and thousands of bungee cords, little hooks on each end, and by doing that, you make essentially a net, or essentially ultimately a filter. And those, when it's intact, that is in such a way that there are only very small holes that go through. And what I would consider is those hooks as the podocyte we call foot processes. And if you start to unhook those, if something injures that so that they can no longer hold on to the edges, you start to unwind all those bungee cords, and you can imagine what happens. The holes start to get bigger and bigger and bigger and bigger. So ultimately, where you're leaking everything through. And so our targets of therapy ultimately are to restore the integrity of that, allow those hooks to get back on, and also stop the process of whatever was causing the injury. In terms of focal sclerosis or FSGS in particular, as I said, the reason that it's not really a disease state, it's more descriptive, is that any process that causes the injury to the structure, repeatedly injury, there's a response locally of the kidney. I mean, just like anything else, if you keep injuring, if you have the same part of skin where it gets cut many times, you form scar tissue. And that scar tissue is what we see in the kidney as that sclerotic lesion. So that what we're seeing is really the effect of whatever injury process occurred. And that's of course disturbing to people. Like, well, I already have scar tissue there. That's not a good thing. And absolutely it's not. And so I think identifying, the protein loss earlier on. Now the kidney can heal. So a lot of these things can get better if the sort of onslaught of injury, whatever is causing the injury, can be stopped. And that's where kind of our therapeutic interventions are really trying to focus on. So again, we know a lot more now than we did a few years ago. So this is a structure of this podocyte and these foot processes that I've talked about. And you can see all these little components in the bottom right. You see all these different proteins that we've identified that are key to maintain this integrity, maintaining those hooks on that open drain. And identifying these is key for multiple reasons. One is, of course, that we can potentially find targets for therapy. Because if we think that one of these is being attacked, or one of these are loss of integrity of one of these proteins is why people are losing protein, then something to help restore that can be helpful. It also has given us a better understanding of inherited causes of protein loss, because we know that genetic variations in each of these, as well as many others, can lead to the clinical manifestations of nephrotic syndrome. Now, there's even more to it than this, but I think that again, this list is helpful to understand. Okay, we are now understanding how complex this relationship is, and also why then you see so many variations of this, because any of these can be affected. So where were we and where are we now? And so this is two slides I'll show. This is where we were in 2015 in terms of the number of trials available for these rare diseases. So you can see not very many. Now this is 2020. And you can see the amount of progress that's being made. And yes, not all of these will necessarily be viable options, but you can see that there's definitely a commitment from industry, from investigators, scientists, physicians, et cetera, to really identify new and better therapies, because none of us should be satisfied with the status quo. Now, in terms of, how do we treat, if I have a patient with one of these conditions, nephrotic syndrome, there's sort of, general principles. I put two categories there: managing the complications of the nephrotic syndrome or protein loss, and then reducing protein in the urine. So usually the immediate thing is, of course, management of complications. They initially present, oftentimes if there's fluid retention, blood pressure can be high, they're losing lots of protein, so they're at risk for they're at higher risk for infection because they're losing antibodies as well. So we try to, again, do what we can to help alleviate those complications. Oftentimes, diuretics, salt restriction, trying to reduce other burdens that can add to the kidney in terms of high animal protein intake or processed food. Again, not only are we worried about the kidney, but of course the effects on other organ systems. So we know that one of the biggest things we get concerned about is that associated with protein loss through a pathway that we can go in more detail, is oftentimes high cholesterol. And so it's not necessarily the kidney problem itself that ultimately causes complications for people longer term, but it's high cholesterol, the effect on blood vessels, the effect of high blood pressure on blood vessels. And so they are at higher risk for cardiovascular illness. And so lowering that cholesterol, lowering their blood pressure becomes a mainstay of initial therapy. Now, ultimately, our goal is to reduce protein in the urine, because most, if not all, of these complications are as a result of the protein loss. So why do we look at protein in the urine? Why do we target reduction of protein loss? For two reasons. It's it's an indication of how much stress is on a damaged glomeruli, like a damaged kidney filter. The more protein loss, it means that there's more pressure at that kidney filter. I sort of use the simile or the analogy that it's you're overworking the kidney. But also, the more protein loss tells us how leaky that kidney filter is. And so as protein loss reduces, we know that we have been able to lessen the leakiness of the protein. Now, there are sort of more general principles of reducing protein loss. There's medications called ACE inhibitors or angiotensin receptor blockers. We call them inhibitors of the renin-angiotensin-aldosterone system. These are conventionally blood pressure medications, but they lower specifically the pressure at the kidney. The new class of medications called sodium glucose transport inhibitors can also help achieve this. But ultimately, these are, again, more general ways to treat protein loss. And what we really like to find is disease-specific therapy. So what is the best therapy for a person with minimal change? What is the best therapy for a person with FSGS? But sometimes, again, as I said, specifically with FSGS, if it's not caused by the immune system being activated, then medications like ACE inhibitors, ARBs, sodium glucose transport inhibitors, they can still be the mainstay of treatment, and not steroids and things like that. So it really depends on each individual. Now, in terms of selecting the treatment for you, again, first and foremost, as has already been outlined, you got to find the right partner, because it's a difficult journey. And anybody that's experienced a rare disease knows how anxiety provoking it is, how difficult it is. And having someone that you feel confident or that you trust is, of course, key. And as already been outlined, these are not common conditions. This is not diabetes, not high blood pressure. And so you have to have someone that has seen this so that they appreciate the variations. They know what therapy options are there. Oftentimes they may have access to clinical trials. So that is important, but that's not enough, right? You can't, just because I may have seen, hundreds and thousands of patients with this, that's not enough to necessarily be the right care partner for that person, because they have to, in my opinion, they have to have empathy. You really have to think about a collaborative approach. What's going to work for that person? Humility, I think, is an incredibly important thing. I tell my patients, I always encourage them, if they feel interested in getting another opinion, they definitely should. But I say one thing: if you walk into a room and any nephrologist tells you that they know everything about these, everything there is to know about these diseases, run the other way, because we know, as I've already outlined, very little, and we have, we know that there is a lot more we don't know than we know, and so we have to understand that, and also help kind of convey that. Um, Availability is another thing. What I mean by that is, Josh Tarnoff already outlined, being able to access a specialist within a given period of time. If you call for an appointment, they say, yeah, we'll see you in 3 months. I mean, come on. Like, this is not something that can wait. You need to have someone that's, a clinician that will be available. And sometimes that means, getting overbooked, coming at the end of the day, beginning of the day, whatnot, but you have to have that. And the Kidney Health Gateway, the specialist, definitely has been a great resource, I think. And the list is building every day. And people have outlined, say, if I love my nephrologist, can I nominate them? You can definitely ask them to be, to self nominate. And there's a important vetting process, but it's not based on titles or accolades or publications or anything like that. It's really about them being a good person for patients with glomerular disease. Now, again, each treatment has its ups and downs. Nothing, no matter what therapeutic intervention we choose, we cannot say that any of them are completely benign. And so when you pick one, you have to think, okay, what is the likelihood of the effect? What's the intensity of the effect, meaning how much of a response can I expect? And then duration, because again, that changes depending on the condition, depending on the medication. So again, finding that out for each person is different, and it really is not a one size fits all approach. Now, that being said, there are some standard approaches that we generally adhere to, and this is from the draft of the KDIGO guidelines of 2020. So KDIGO is the Kidney Disease Improving Global Outcomes. Essentially, it's a consortium of, again, the experts in the field that come together within each area of nephrology: glomerular disease, high blood pressure, etc. And last year, they met and developed these guidelines. They then present them for public opinion or public commentary, meaning nephrologists, patients, NephCure, saying these are the guidelines we propose. Are the things that you can identify that we've left out? And that process, once that's complete, then this will be finalized and released as guidelines. But they do have a draft, and this is still, again, the approach that we take. In terms of minimal change, fundamentally, it's still approached as a steroid responsive disease, and still the vast majority, even of adults, but not all, will respond to steroids. So unless there's a contraindication, the initial therapy is based on using steroids. However, the difficult part is that relapses are common. Over half of patients, adults, will relapse. And so this is not oftentimes a one and done. And so you have to have a plan in place or consideration in place of what comes next. As you can see on the right, individuals have frequent relapses. There are other options. And they are listed here. An old drug called cyclophosphamide is still oftentimes advocated as the first line because of usually you can have a sustained remission afterward. But again, that has to be individualized because cyclophosphamide does have quite a bit of toxicity. Newer agents, meaning newer than cyclophosphamide, but still decades old, particularly rituximab, or we call the monoclonal antibodies, have become more and more an option in this particular category. This individuals have relapsed, but steroid responsive minimal change disease. So if you relapse or you're steroid dependent, one option is using we call calcineurin inhibitors. So drugs that have been developed for many years in use in kidney transplant patients and are used as another common therapy in proteinuric kidney disease. The two most commonly used are tacrolimus and cyclosporin. They can be very effective. They can be effective for steroid, even individuals that do not respond to steroids. However, the problem oftentimes is that it's difficult to come off of them because the way they work is probably more about kind of reinforcing that anchor, that hook to the kidney filter. And so once you take it off, that process of whatever started the injury can recur and protein loss begins again. Rituximab has become more and more a favorable option. Rituximab, for those of you not familiar, is we call a monoclonal antibody against B cells, which is one of the types of white blood cells, immune cells. So monoclonal antibodies, what they would do is basically they tag a specific target. So rituximab targets something called CD20. CD20 is a little sort of badge or a marker on these B cells that tell the body that that's what it is. And rituximab binds to that or tags it. And when it does that, the immune system clears it out. The rationale behind that is that we think that some of the nephrotic syndromes, some minimal change, some FSGS, their disease process is either originated or highly tied to this type of cell, the B cells. And so depleting them, knocking them out, stopping the antibody production, then can then allow for the kidney to stop being sort of continuously affronted by the immune system and lead to a sustained and very near complete or complete remission of disease. Now there's debate on when to do it, how many times to do it, meaning that do you give one dose or one single course? Oftentimes it's given either weekly for 4 doses or every 2 weeks for 2 doses, or do you give it sort of in a structured, continuous way, meaning the effect of the medication is usually about 6 months. 6 to 9 months is when the B cells start to sort of resurface. So some people have advocated that you continue therapy every 6 months for a fixed period of time, whether that's 18 months, 24 months, longer. And again, that has to be individualized to the person, depending on what their history is. It has to be balanced out with the risks of doing that. And so it's not a universal approach. Individuals that are steroid resistant, minimal change, again, it does happen. It's not as often as an FSGS, but the options are not as good, but there are some. So calcium inhibitors, as we've talked about, ACTH, which is a hormone that our body makes that's sort of a precursor to steroids, but also may have a separate effect on the kidney, has been increasingly used as a therapeutic option. There's something called the liposorber, which is a filter, not a dialysis filter, but a different filter that removes cholesterol and things that are bound to cholesterol, which seems to be part of the process that can cause protein-losing kidney disease. And that's also been used in Japan for many years. More recently, it's been expanding from initially pediatrics to post-transplant people that have recurrent disease to individuals with a resistant disease. Now, I will move on to FSGS. And as I've said, really, FSGS is not one disease. And it's really an overlap of many different conditions where the final pathway, the final result is this scar that's developed after that podocyte, that cell I've mentioned, is repeatedly injured. And this is one way to classify. Again, this is, I know, a little bit, a lot of things that are complicated on this image, but so I'm just going to walk through them. Let's walk through the bubble on the left. We call the permeability factor mediated podocytopathy. Long term podocytopathy. Let's start with that. So the podocyte, as I said, is the cell that really is the anchor for the filter. So when we say podocytopathy, that's really meaning injury to that cell. This permeability factor is this idea that there's something in the immune system that's causing this. And we say it's permeability factor, meaning that it causes the kidney filter to become more leaky. This is probably what we see in individuals that have steroid responsive minimal change, that have steroid responsive FSGS or dependent FSGS, or particularly those that have recurrent FSGS after transplant. And this is the group that probably has the best likelihood of leading to of steroid responsiveness, but also can be steroid dependent. The other group is are ones that oftentimes are not going to have a response to immunosuppression. One is referred to as the toxic podocytopathy. It's the same concept of injury to the cell, but it's due to a toxin, and that toxin can be an infection. There's certain viral infections. Actually, I didn't include on here, but COVID-19 or SARS-CoV-2 can be associated with this. Some medications have been associated with this. The last two categories we know are not going to be related responsive to immunosuppression. One is those are genetic causes. So these people that have an inherited condition that affects one of those various proteins I outlined, or an inherited condition that affects not just the cell that makes up the filter, but the network or that net that makes the filter, called the glomerular basement membrane. And again, with genetic testing, this is becoming more and more of an option. The last category is what I call hyperfiltration or adaptive. So as I was saying, that anything that causes scarring to the kidney can lead to FSGS. And the way to think about this is the idea between the imbalance between the load on the kidney filter and the capacity of the kidney filter. And so if you have an imbalance of any of those, either you have an increased load, oftentimes it's because of more weight carried around the midsection or on the belly, or if you have less kidney mass to begin with. You had only one kidney you were born with, or one kidney that was removed, or individuals with a low birth weight, because we know that the number of filters that you actually have is largely tied to birth weight. So oftentimes I'll ask people, do you remember what you were, what you weigh when you were born? And obviously, people think it's a strange question at first, but you can understand that it's trying to give us an understanding of what their filter capacity is. So you can see that this is a lot of variation in FSGS, and so it's definitely not a one-size-fits-all approach, but it makes it quite complicated in terms of how to approach treatment. So trying to determine the nature of the FSGS is really the key. And so not all FSGS is the same. When people come with a diagnosis of FSGS, try to figure out, okay, what really is the cause here? Do I think it's an immune-mediated process? Do I think this is genetic? Do I think this is they're exposed to some toxin? Genetic testing is much more available now. Insurance authorized, very easy with saliva or blood. And so now it really is becoming more and more a mainstay of the evaluation. Now, this flow chart on the right is the KDIGO 2020 guidelines in terms of how to approach it. And it really is trying, again, to find out who may fit in that category of immune-mediated, where steroids will be helpful. So if you have lots of protein, there's certain characteristics on the kidney biopsy we look at. If you have low protein in the blood, we think that there's enough here to at least warrant a trial of steroids. And it's I can understand the frustration from a patient perspective, say, why do I still need to be on steroids? And unfortunately, because we haven't been able to identify what this actual factor is, the response to steroid kind of tells us a little bit more about what is likely the underlying nature of the FSGS. Meaning, if they respond to steroids, then we're much more confident this is a immune process, and that subsequent treatments, even though you don't have to get steroids each time, subsequent treatments are kind of directed at the immune system. If you are not steroid responsive, then keep continuing to give you more and more immunosuppressive therapies that are going to knock out your immune system is oftentimes not helpful. And as it carries a real risk. So we have to try to identify who's really going to respond so that we can determine what to give them next. but also those people not going to respond, to not keep exposing them to toxic therapies, because it doesn't do anyone any good. So really trying to find out and classify, and we need to be better at this. I'll be the first one to admit this. So genetic testing, looking at the biopsy, all these things have to be considered when you're thinking about the therapeutic approach. So again, this is another way to look at the approach. If you have nephrotic syndrome, which means heavy protein loss and low protein in the blood and fluid retention, you consider first-line therapy. But you can see on the red, there's a very strong emphasis on genetic testing now, because it is, again, trying to better identify the condition and really prevent you from being exposed to things that are not going to be helpful. And lastly, hopefully, as we get to a more precision-based approach to therapeutics, we can better say, okay, this person has protein loss because they have a genetic variation in TRPC6 or type 4 collagen. So this is the way we should approach them, as opposed to the sort of one-size-fits-all approach that we've used for so long. Now, in terms of the therapy, again, the first-line therapy still is high-dose steroids, which again is frustrating as a nephrologist, believe me. But again, it is still where we approach things if there's not a contraindication. And it's a high dose, and which, as I've said before, I hate giving this prescription. But if they respond and you can taper them off and they can be done with this, then that makes it worthwhile. If there's contraindication steroids, or there is other resistance to steroids, then other therapies become the next step. Now, I put a question mark next to rituximab as well as ACTH, because rituximab in particular, if people are not steroid responsive, then it's a good likelihood they don't have an immune-mediated process. And so oftentimes they will not respond to steroids. I'm sorry, rituximab. And so giving that, again, has important implications. The most timely implication right now is when you give rituximab, as I said, you knock out B cells, which are producing new antibodies. And so this has very strong implications in a pandemic. If you give rituximab, you will almost definitely not respond to vaccination against COVID or anything else really for 4 to 6 months. Now, you may have your other parts of your immune system may be able to respond, but it has changed. The pandemic has forced us to really think about this, because if I'm committing someone to more rituximab, I have to really try to think about, okay, well, are they vaccinated? Can we get them vaccinated first, then give rituximab a few weeks later so they can already develop an immune response? If we don't, then what is their implication for how they live their life? So these are real, each decision of this is not without consequence. So the questions that oftentimes come up are, okay, I've responded to treatment. How long do I need to continue treatment? It really depends on which therapy you're on. And again, each individual, sort of the risk benefit. For steroids, again, that taper should be, if you respond, once you have a response, the taper should be over a few months. Definitely less than a year, or probably less than 6 months. And really the last part of the taper is the lowest doses. For calcineurin inhibitors, tacrolimus, cyclosporin, it's a much slower taper, because we want people to have sustained response and then very slow over the course of a year, start to slowly dial down the dose and to see if there's evidence of relapse, because you don't want that to happen. And with rituximab in particular, again, a lot of complicating factors. Some people have advocated a sort of initial therapy and then a reactive approach, meaning that if you have a relapse after 6 months, 9 months, 12 months, then give another dose. Some people have advocated, as I said, sort of this continuous, referred to as continuous B cell depletion. So keep giving doses for every 6 months for the course of 2 years. And the rationale behind that, and it is an approach that I will use oftentimes. The pandemic has made it more complicated, but because really we know that the immune response, the idea that the immune system knows how to attack the kidney, is very deep seated. It's something that's very, if you clear the immune response once, that may not be enough, because there's still some cells that are lingering around in the bone marrow or in the lymph nodes or somewhere that still know how to cause this process. On the other hand, for some people, it's sort of one and done. But if it is more deep-seated, then you kind of have to keep knocking down that. I describe this as a full reboot of the immune system. Now that is not without risk, and that's where it becomes very important to individualize treatment. Just think about, how bad was the relapse? What is the potential risk you can take of not doing therapy? And again, what's the environment? In the setting of a pandemic, I've been more reluctant. If people have had a complete response and they've been doing well, I've been more reluctant to say, okay, yes, for sure, you need to keep getting doses, because the implications in terms of their risk for infection. Now, we talked a little about a clinical trial enrollment, and I think it's an important discussion to have. I think it's an important thing to consider. I think it's also not for everyone, I should say. I think, as I said before, as a clinician, most of my job is to take care of patients. And so if I'm going to consider a clinical trial, I have to really in my heart believe, and the evidence has to suggest this, that if they're in a trial, it's a randomized trial. So meaning that there's two arms, that both arms are equivalent from the standpoint of what we know based on the science at that time. Now, the talk about a placebo is something that comes up a lot. And yes, there's oftentimes a placebo. What I also refer to as an active comparator, because at the minimum, people should be, in whatever arm of the trial they're in, should be receiving the standard of care. So you can't just have a placebo, just a placebo. They have to, if there's a standard of care that's established, no matter what, for a disease, they must be on that. And no trial would be designed or approved or taken up if not that. But the idea of a placebo, we should understand, is not purely that you're getting sort of nothing, but you should be at least getting the standard of care. That being said, though, as I sort of outlined before, I tell people this. It's really about paying it forward. As a clinical trial, you will get extra attention. We watch people in our clinical trial like a hawk. We want to know everything. We want to know if you got a hangnail. We want to know if you cut yourself shaving. We want to know everything about in terms of what is going on. But in the end, we don't know what arm you're on of the trial. We also don't know if the therapy is really effective. As that was the case, we'd already be using it. And so this trial may not actually, quote unquote, treat your disease better. Now, undoubtedly, though, it will help us understand what therapies work. And so I tell people, this is a selfless act. Yes, we are going to help you no matter what and do whatever we can, but a large degree of this is you are giving to us and the rest of the community. And we are extremely grateful for people that step up to do clinical trials, because without them, we would never get anywhere. And so if you consider a trial, even if you decide that it's not for you, even if it turns out you don't fit the criteria, just the fact that you express interest and that's to us is we are grateful for, because that's the only way we're going to move forward. And that's the only way we've, on the cusp of moving forward now. As I said, equipoise, is this really the best thing for me? And, it has to be for each individual. There also is the concept of rescue therapy. Now, if people are truly getting worse while in a study, it's not that we do nothing. We have to think, okay, what is our safety valve here? Again, if we really thought there was a better treatment, we should have already been getting it. They shouldn't be necessarily randomized to a trial. But that being said, if things are really getting worse and there's maybe an option that maybe will work for someone, we can say, okay, we can try salvage therapy, understanding that that's going to affect the results of the trial in terms of the data, but ultimately what's most important is the individual person's safety, their outcome. And so, and that's a discussion that certainly to have between you and the investigator. Now there's some real clinical trial successes. Duplex, which is the trial of sparsentan and FSGS, the preliminary data is positive. We'll hope for the final data to be positive so that FDA approval can occur. You may have heard that the class of medications, sodium glucose transport inhibitors, have shown to be, and actually was FDA labeled to be utilized in people with kidney disease at high risk for progression. So I would consider that people with protein loss in the urine. And that's based on a study called DAPA-CKD. And within that study, they did include people with rare protein-losing kidney diseases, IgA nephropathy, FSGS, and they saw that in those individuals, it can still be quite helpful. And so really that's the first drug that's been approved specifically for kidney disease in a very long time. There's a lot of other active clinical trials. You heard about the POTO trial earlier. You heard about the Traction 2 trial, which is through Goldfinch Bio. There's the liposomal that I mentioned already is being actively studied. And then you heard about the trials specifically for those that have the APOL1 high-risk gene variant. And that's through Vertex and Pfizer. So what about transplant? Ultimately, unfortunately, there are people that progress and they require transplant or dialysis. They have transplant. The problem with FSGS, even minimal change, is that there can be recurrence. And the cruel irony is that if you were steroid responsive, you're more likely then to relapse because then there's something in the immune system that still may be there. On the other hand, if you're steroid resistant, those are the individuals that are less likely to recur because it's likely that they're not, there's not as much of an immune process there. If you have a genetic cause, certainly are not at high enough, higher risk of relapse because you've replaced the genetic problem. Unfortunately, it's demographics. They are vary depending on the individual in terms of the risk of relapse. There are people that are higher risk, the lower risk. White males with FSGS are the highest risk because oftentimes they're the ones that have this immune system mediated disease. If you've had a recurrence in a previous transplant, you're at high risk to have another recurrence.
Dr. Udani?
Yes.
Somebody's asking, with each relapse of minimal change, does that play a factor in progressing to FSGS?
It's a very good question. And the answer is yes. So that you'll see this, I take care of adult patients, but we oftentimes get individuals that had condition as children or adolescents, and they have relapse, then they have remission, and then they progress to adulthood and they have protein loss, and you rebiopsy them and they have FSGS. And that really sort of speaks to the point that these are not necessarily different diseases. It's not that the minimal change changed in FSGS. It's just that the repeated injuries have now caused that scar tissue to develop. So in most cases, we won't rebiopsy anymore because we know what the condition is. Whether it's FSGS, whether it can be called FSGS or not, now is not the issue. You had a steroid responsive, an immune mediated, circulating factor related, podocyte injury. And so the approach to treatment really should be along those lines. So there are some strategies to reduce recurrence. I mentioned plasma exchange, again, liposomal. These are ways to try to remove whatever it is that's causing this. Those, of course, are limited in how long you can do them. You don't want to trade dialysis for another therapy that you have to go for twice a week and get filtered through the blood. The immunosuppression post-transplant we know, help with, as a lot of the drugs are overlapping. Steroids, calcium inhibitors are used in transplant as well as in FSGS, and so they can be helpful. There's some other things like rituximab, as I already mentioned, has been utilized with some success, ACTH as well. But again, it's got to be an individualized approach. So I'll finish off with a few, last points. Here's my wish list as a nephrologist. So first thing, I'd like to have an easily accessible, non-invasive lab test that tells us the etiology of disease. So many of you may be familiar with membranous nephropathy. It's one of the other rare protein-losing kidney diseases. And about almost over 10 years ago now, they identified that the process, the antibody and antigen, the disease-causing process, is an antibody directed at, in a large proportion of people, 65, 70% of people, is an antibody directed against something called PLA2R. And this is now a blood test we can measure. So someone comes in membranous nephropathy, I can measure PLA2R, I can give them medication to treat their condition, I can see the PLA2R level clear, and I know with confidence that their protein losing kidney disease will improve. And also it can help with diagnosis without having to have another repeated biopsies and things like that. I'd love to have that for minimal change, for various causes of FSGS. There may be close. There's a group out of the Harvard Medical School that's seen that a subset of patients with minimal change have an autoantibody to something called nephrin, one of the proteins I mentioned earlier. And so they are developing a way for us to check that in the blood. Hopefully in the next few years, we'll have that available for a subset of people with, minimal change and FSGS, if they have an autoantibody to nephrin, and we can use that as a marker of disease, but also a marker of response to treatment. I'd like to see other better ways to look at treatment response. All the things we've talked about are very indirect: protein loss, kidney function. These are not really telling me what's happening at the cellular level. And that would give us a better idea of kind of how much success we're actually achieving. Definitely would like a non-steroid option as a first-line therapy for both these conditions. And along those lines, non-immunosuppressive therapy for initial and maintenance treatment. Again, the pandemic has highlighted, while we have used these drugs, and oftentimes with success, they carry their own risk. And we've had to definitely consider with each person, what are the trade-offs of doing that? And then lastly, of course, what if people do get transplanted, how can we better predict the risk of recurrence and really intervene appropriately? So I will stop there in terms of what I had set to say, and I will leave it up for some questions. I think we have some time for questions, so I will leave it up to you guys.
Sure. Well, Dr. Udani, thank you so much. This has really been interesting. So folks, if you have any questions, please put them in the chat. We do have one from Jean. What are your thoughts? Hopefully I'm reading this correctly. What are the thoughts to be what are the most likely causes of relapse for minimal change? And would, I think, like, if you taper off the prednisone too quickly, would you relapse? And I think the last part of the question is, what effect of Medrol infusions on holding off any relapse? I hope I read that correctly.
Okay, so good question. So cause of relapse, yes, certainly if you, we know that the steroid taper does have to be slow at the tail end if you taper too quickly. And the idea in my mind, and I'm not a molecular biologist, but is again that residual effect of whatever is causing the immune injury is lingering, and so as you start to taper off, you need to have a little bit of that anti-inflammatory effect of the steroid. We know these are immune system ultimately triggers, and so we know that I think in the pediatric literature even much more, during viral infection season, cold and flu season, we see more relapses because the immune system gets activated by something, not just influenza or not say COVID, but any sort of what otherwise would be a benign infection triggers the immune system and sparks this kind of relapse. In general, if I have someone, again, as an adult patient that I am seeing that has frequent relapse, I try to steer away from steroids once they have achieved remission. So I will use things like rituximab much more readily or earlier on, because I do see that, and again, the steroid responsive approach, the steroid responsive individuals, they can have a very good sustained remission with rituximab. So other ways like using low doses of steroids, Medrol infusions, certainly those are ways to potentially, again, keep things quieted, but if you would ask me what I would prefer, I would kind of go toward something that's perhaps a little more definitive, but also something that's a little more targeted in terms of the immune response. So steroids are upfront what we reach for to give us this idea whether people are steroid responsive or steroid resistant, and because some people and also because some people respond very quickly to steroids. But once I know that response, I try not to use them again unless that's really the only option we have, or for whatever reason they can't get any of the other medications we've talked about.
Great. I have another question here. Is it common to have a single response of steroids, or, gosh, I wish I had a better medical term, tacrolimus? Is it common to have a single response to steroids or tacrolimus? This happened to our daughter, and we couldn't get another response even with increased dosage. Rituximab has been working so far, but they just came off 21 days of that.
Yeah, so definitely there's this idea that people have we call primary steroid resistance versus secondary steroid resistance. Um, uh, so people can be responsive to steroids the first time and then not have it subsequent times. And so this is definitely, I would say, not the norm, but certainly frequent. And that's where as you've already outlined, things like rituximab and cyclophosphamide can be more effective. We don't. The problem is we don't really know why steroids work in this. Right? We know that it's an anti-inflammatory. We know that it's immunosuppressive to some degree. We don't know what it's actually achieving, and so if the other difficult thing is you can say, okay, well, people are steroid resistant initially. They get the disease the first time, steroid resistant. So we think, oh, maybe they don't have a steroid responsive disease, and then they get transplanted, and then they recur. So it's suggesting that they really did have an immune-mediated process. And so this is where finding other pathways to target the immune system really becomes key. Calcineurin inhibitors, tacrolimus and such, are I think that I think we know that their benefits or their mechanism by which that they help with reducing protein in the urine is not just by the immune system effect. It's really about kind of a local, again, reinforcing that kidney filter. But again, if the kidney filter is being constantly affronted, then they will not be enough. And so I think that, again, the longer you've had the condition, there's more of a chance for the immune system to keep at it. And so then your response to therapies becomes, oftentimes becomes less. Especially, I see this especially in the adult population. And so that's why I'm more, and again, this is not the guideline, this is not what necessarily the scientific evidence suggests, but I'm much more likely to give things like rituximab or cyclophosphamide earlier on to really try to, again, get that reboot of the immune system, even to the degree that, again, and I use a disclaimer, this is not based on randomized controlled trials, but this is based on experience, is if I have an adult who I have a high suspicion that they're going to relapse just because they're an adult and their nephrotic syndrome was quite bad, and I know that another course of steroids is not going to be a good idea for them, we'll use steroids up front, achieve remission, and then give rituximab at the same time to sort of consolidate the remission. And that way, now if you give rituximab too early in that process, though, it can be difficult because, again, if they're losing a lot of protein, they may lose the rituximab itself. And the antibody may also be lost in the urine. So you try to achieve a remission as much as possible with whatever agent, give the other more definitive therapy, and then taper off the other one.
Wonderful. I think we have time for one or two more questions. This person asks, what do you look for in clinical trials, or do you look to your patients to bring clinical trials to you?
Well, we do clinical studies, so we have access to most of the trials that are ongoing. We have a network. I'm in Chicago, so we have a network of other medical centers that have clinical trials going. So I'd say I'm pretty in tune with what's going on, and again, really want to find the right one for the right person. I think people who have steroid-resistant FSGS or steroid-resistant minimal change, for that matter, should be considered for a clinical trial early on. because none of the other therapies are really have been, consistently effective. So, and again, I have to look at the protocol of the clinical trial. Can you be on concomitant, calcineurin inhibitors? Can you be on other therapy? That can, that's what I kind of look for. But I look for that earlier on. If a patient brings up a clinical trial, absolutely. If it's one I'm not familiar with, then we want to investigate it. Just by virtue of what I do, I'd say it's not the norm. But I think that's, but I'm sure it's true for individuals who are not doing clinical trials routinely. I think you have to have an open mind. And I think, again, there's no harm in finding out. Like if you go to a clinical trial site, you talk to them, you get screened, you haven't committed to anything. You've just committed to hearing what they have to say. And if you look at it and you talk to the investigator and you talk to, your own physician or whoever you trust, you think it's the right thing for you, then by all means, we would love it. But I think getting the word out and expressing interest, and you have every right, if your own clinician is not involving you or is brought it up, you have every right to seek it out. And I think that's where the gateway is so helpful, because you can search by zip code and location and your disease state and say, okay, what trials are available to me locally? And, can I, and you don't need a referral, you don't need anything, you just need to find the person and contact them.
Great. You know what? We'll end with one last question. What are your thoughts on CellCept for adults who's steroid responsive, but steroids are too toxic for the patient?
No, I think it's a decent option. I think it's sort of the same pathway as things like rituximab or cyclophosphamide. I think it may not be strong enough at times. So, usually favor cyclophosphamide initially as an approach. If cyclophosphamide toxicity is unacceptable, then mycophenolate or CellCept is the next option. Our clinical data, or our scientific data, has not suggested CellCept to be consistently one. But I think along the path of someone who's steroid responsive, I think it has a potential role. Steroid resistant, I have very high doubts that it would be successful.
Great. Well, there are a couple more questions, but I know we have to end this session so we could get into our regional community sessions. Once again, Dr. Udani, you've had over 30 some odd people come in this in one of our large groups, and I can tell just by the comments. I hope you were able to see some that people have really appreciated your insight and everything that you've been talking about today. I have cut and pasted some of the other questions, and maybe we can, I know Kelly's going to do a follow-up email. Maybe we can have those answered. But as you see on the screen right now, we want to say thank you to all our sponsors who helped to make today's Patient Summit happen. We're going to be taking a short break from 2:40 to 2:50. And